Hello, this is Dr. Kim Jeong-gul. Today, I will lecture on vertical analysis. It is overbite depth indicator ODI. Many orthodontists use vertical analysis. Why is vertical analysis so important? We need to distinguish between high-angle open bite and low-angle deep bite. In addition, the vertical methods can be classified as deep bite tendency, normal over bite, open bite tendency and open bite. This patient has a normal over bite, but the bite may reopen or close during treatment. Basically, the skeleton can be divided into a brachyfacial type with strong muscle and a long face type with weak muscle. In the case of the low-angle type, strong muscle force acts in the vertical direction. On the other hand, in the case of the high-angle type, the posterior face height is short and has a steep mandibular plane. And when the gonial angle is large, not only the strength of the muscle is weak, but the direction of the muscle is also oblique. Also, in the case of lower angle and hypodivergency, the posterior teeth are located at the rear. This can be said to be less affected by the muscles. On the other hand, in the case of high-angle type, the posterior teeth are located to anterior. This can be said to be less affected by the muscles. This 80-year-old female patient chief complaint is protrusive lips and overjet is 8 mm. It is necessary to determine whether this patient is an open bite or a deep bite. Should we check the occlusion first for this, or check the skeleton first? We need to check the skeleton first, because the treatment direction can be completely different. If this patient is diagnosed with a deep bite skeleton, cervical headgear will be used to move the teeth located in the anterior part backwards. By the way, if this patient is an open bite skeleton, when using cervical headgear, the mandible will be located more and more posteriorly, but the class 2 relationship will be severe. So in this case, hypal headgear should be used. Most of the edentulous patients show a class 3 malocclusion pattern. But if dentures are inserted, it can become normal in an anteroposterior position. That is, it can be said that the sagittal relationship and the transverse relationship are affected by the vertical relationship. In other words, in the case of the high-angle open bite, the activity of the muscles is weak and the teeth move easily. But in the case of the low-angle deep bite, the strength of the muscles is large and this makes it difficult to move the teeth. These are measured through the mandibular plane angle. As shown on the left, if the MPA is large, anyone can easily distinguish that it is a high-angle type with long face. On the other hand, if the MPA is small, as shown in the picture on the right, it can be distinguished that it is a low-angle type with deep bite, and it needs to be classified into the following 5 types. 1. Normal bite. 2. Skeletal deep bite, that is skeletally and dentally deep bite. 3. Dental deep bite, that is skeletally normal or open bite, but dentally deep bite. 4. Skeletal open bite, that is skeletally and dentally open bite. 5. Dental open bite, that is skeletally normal or deep bite, but dentally open bite. Many doctors use mandibular plane angle to classify the skeleton. In particular, it is evaluated by looking at the angles formed by SNMP, FHMP, PPMP, and OPMP. The method is easy, but its limitations do exist. So, which of the vertical methods should we use? MPA, GA, ODI, PPMP angle, AFH ratio, and so on. There are various measurements. There is a patient of A, B, C, and D as shown in the picture. Looking at patient C, it is an open bite of the evaluation. Results of GH to GON, in S to GON, Anstons to GON, OMA, and GONAL. In case of patient D, all result values are deep bite. In the case of open bite patients, we will use the appropriate treatment method. And in the case of deep bite patients, we will use the proper treatment method. But we need to look at that results again. In the graph above, there are many areas where the two distribution lines overlap. In this case, it will not be easy to differentiate between open bite and deep bite. On the other hand, if you look at the graph below, you can see that there are few overlapping parts of the distribution map. In this case, you can easily discriminate. So it is necessary to find out which measurements are the most reliable in vertical analysis. To differentiate this, we use ROC analysis. For more information on ROC analysis, please refer to the basic course. ROC analysis consists of sensitivity and specificity. It can be said that the more reliable each measurement value is located from A to B direction. For example, when evaluating a Class II skeleton, points such as A and B and APDI mean that the better the analysis method is toward the B direction. Dr. Wardlaw analyzed the skeleton of 68 open bite patients out of 1541 orthodontic patients. The conclusion was that when discriminating the dental open bite, ODI is the best analysis method compared to other measurements. The contents of ODI are also included in the paper published by Professor Kim in 1974. He evaluated 119 children with normal occlusion and 500 malocclusion cases. Group 1 is a normal occlusion, Group 2 is a deep bite, and Group 4 is an open bite. At this time, he found that the distributions of open and deep bites were different in Class 2 and 3 malocclusions. In the case of Class 2 malocclusion, are there many open bite cases or deep bite cases? In that case, there are many cases of deep bite. What about Class 3 malocclusion? In that case, there are many open bite cases. So he said, wouldn't vertical analysis be influenced by anteroposterior analysis? After thinking, he added one line. That is the AB plane. He evaluated 12 items, and the sum of AB to MP and FH to PP was the highest. The baseline is mandibular plane angle MPA. MPA uses different measurement points depending on the method of analysis. Tweed analysis uses tangent to lower border of the mandible. In the Steiner analysis, the line connecting GO and GN. Downs analysis uses the line connecting GO and NE. Like the Downs analysis in MEAW, the line connecting GO and ME is used. GO refers to the point where the ramus tangent of the mandibular posterior and the tangent of the mandibular inferior border meet. ODI is the sum of two items. That is, AB plane to mandibular plane angle plus or minus palatal plane to FH plane angle. At this time, depending on the slope of the palatal plane, it has a negative or positive value. The green line means that A and S is located down and has a positive value. On the other hand, the red line is located above A and S, which means negative value. As shown in figure O on the left, when the ANS is positioned upward. It shows that the maxillary is moved anteriorly and upward, which means that the palatal plane angle has a negative value. So what kind of malocclusion is likely to be? Since the anterior part is raised, it is more likely to become an open bite, and in the posterior relationship, it is more likely to show class 2 malocclusion. Figure B shows the case where ANS is located down. In this case, it is closely related to deep bite or class 3 malocclusion. ODI allows you to tell whether the anterior vertical problem is in the maxilla or in the mandible. In the case of figure A, the palatal plane angle is normal at 0.6 degrees, but the FMA is 33 degrees and the ODI is 60 degrees. Although the ODI has a small value of 60 degrees, it can be said that there is a problem with the mandible rather than the maxilla because the FMA is large. On the other hand, in the case of figure B, the FMA is in the normal category of 29 degrees, but the palatal plane angle is -5 degrees. In this case, it can be said that there is a problem with the maxilla. ODI values by race were evaluated. Please remember that the normal value for Caucasians is 74.5 degrees and 72 degrees for Asians. As shown in the figure, the skeleton can be evaluated by dividing it into the x-axis and y-axis. The vertical method corresponds to the y-axis of the figure. We can easily differentiate between deep bite and open bite by ODI value. The smaller the ODI value, the more open bite or open bite tends to be. The larger the ODI value, the more likely there is a deep bite or deep bite tends to be. In summary, an ODI value of less than 65 means open bite or tendency, and greater than 78 means deep bite or tendency. This is the picture we saw at the beginning of this lecture. Patient C was classified as open bite by the conventional analysis method, but the ODI is 79.5 degrees. Since the ODI value is greater than 78, patient C shows a deep bite pattern. On the other hand, declassified as deep bite. But the ODI value was 67.5, which is less than the normal value. So it can be seen that there is a tendency to open bite. ODI allows us to know: first, skeletal open bite when the ODI value is in the 50s or 60s. In the 70s, open bite tendency, normal bite. If far above 70, there is a tendency to deep bite. And remember that if it is over 80, it is a skeletal deep bite. Second, patients with open bite or open bite tendency tend to have a weak masticatory force, so there is a greater risk of tooth extrusion. If the tooth is erupted, the open bite can get worse. Third, patients with deep bite or deep bite tendency tend to have a strong masticatory force, so the risk of tooth extrusion is not high and tooth movement rarely occurs. Fourth, when a patient has a high ODI value, he/she has a greater tendency of anterior crowding and deep bite. So in the case of deep bite, the growth direction is when the mandible descends and the chin comes forward. Then, the lower anterior teeth are moved posteriorly. So the anterior crowding is also closely related to the vertical problem. Please remember this. Always consider the vertical relationship when resolving anterior crowding to achieve good treatment results. Fifth, patients who have a low ODI value show relatively faster tooth movement. To achieve stable anterior teeth alignment, the anterior vertical relationship must be adjusted. If there is an excessive ODI value, bites are highly likely to get deeper. So an extra careful examination if possible. Non-extraction treatment is required in this case. If the ODI is over 80, it means that the AB to MPA value is large, which means that the MPA can be flattened like a red line. In this case, muscle strength is strong, so non-extraction treatment should be performed if possible. If the premolar is extracted, the bite is likely to deepen. ODI less than 65 means MPA is steep. In this case, the vertical height of the posterior part is short. What will happen if the posterior tooth moves backward during non-extraction treatment? Since there is not enough space to move to the posterior part, there is a high probability that there is an open bite due to the wedge in the anterior part. Many doctors already know that ODI is a good measurement for anterior vertical evaluation. However, there is something you misunderstand. That is, many doctors try to get their ODI value to 74 degrees, the normal value. The purpose of the evaluation of ODI is not to set the value to a normal statistical value, but to evaluate the patient's skeleton. Orthodontic treatment involves first evaluating the patient's skeletal pattern and aligning the teeth within the patient's skeletal frame. Let's evaluate ODI and malocclusions. As shown in the picture above, let's divide it into Class 1, 2 and 3. For Class 2, the ODI value is large. On the other hand, in the case of Class 3, the AB to MPA value decreases, so the ODI value is also small. Thank you for watching.